We're talking today about ketamine, which is an anesthetic drug that's starting to be used to treat patients with anxiety, depression, suicidal ideation. And I'm really pleased to welcome to the webcast Rameen Ghorieshi. You're a psychiatrist here in the Palo Alto area, founder of Palo Alto Mind Body. And you've been using ketamine with some of your patients. So I was wondering if you could just start by telling us a little bit about your background and how you started to use ketamine.
Sure. Thanks for having me here. I went to med school in Atlanta, moved to the area to go to residency at Stanford. During residency, became very interested in addiction treatment, actually, and sort of fell in love with that and really enjoyed those patients and seeing the progress that they can have and how rewarding it is to see them get better. Somewhat haphazardly, years later, I fell into ketamine because I had a patient who came to me and she had tried many medications. It was somewhere in like 30 or 32 different medications, sufficient dose, sufficient duration of treatment to be true failures, and really started reading about what can help patients like this. Did a lot of research, found ketamine in the literature, and then started asking around, asking colleagues at Stanford, how do we do this? What's this all about? No one knew at that point. This was 4 or 5 years ago. Really, people had just started using it. So one of the clinics in LA had just started around that time. This happened with another 1 or 2 patients, and I finally said, hey, I got to do something about this. Did a lot of research, trained with an anesthesiologist, and started offering ketamine to my own small cohort of therapy patients, those who really needed it. And the results were so remarkable that I opened it up to referrals in the community, and it's really exceeded my expectations.
Tell us what happened with those patients that made you pay attention.
Yeah, so the particular patient comes to mind where I saw her, actually the first day she came in, she revealed to her mother that she was significantly suicidal for a very long time. And this was not just some thoughts. This was to the point of, I have a plan. Now I'm trying to figure out when I can do it so it's not around someone's birthday or around a holiday. Who's going to find me? So really sort of devastating. Over the course of the next few months, we did psychotherapy and medications, and she got significantly better, was able to go out, do things, see friends. But when we started the ketamine, I think she may have been the very first patient, first or second patient, and it's almost sounds like hyperbole, but it's as if she was a new person.
Wow.
Right? She now works every day, is thinking about going back to school, and really just a new experience and a new life for her. So a couple of these instances really got me to sort of take note and say, this is something that's really remarkable compared to what we've done so far.
That's astounding. Yeah.
I think these stories are, and a few of the patients I spoke with of yours and people who are going to other clinics in the area, they are just like these miraculous, almost unbelievable stories with the results. And I know that there isn't still this sort of fully fleshed out understanding of exactly what ketamine is doing in patients' brains to make that happen, but what is known about what is happening to produce those kinds of results?
Yeah, we know how ketamine works as an anesthetic, right? So ketamine in general works on the glutamate system in the brain, and glutamate is just one of the many different neurotransmitters that our brain uses to communicate, our nerve cells use to communicate. Others are serotonin, dopamine, norepinephrine, those kind of things. So traditionally you think about ketamine as blocking the NMDA receptor. It's similar to illicit substances like phencyclidine, PCP, and more common things like dextromethorphan, cough syrup. They block NMDA as well, but we really don't think that's why ketamine helps with depression. More likely it's taking an action at a different glutamate receptor, called AMPAR, and that leads to a downstream chain of events that's not well understood, but it's that downstream chain of events that we believe does one of two things, maybe both. One is promoting more of a substance called brain-derived neurotropic factor. Neurotropic, nerves grow. This is how we think that ketamine helps maybe with what's called neuroplasticity, sort of the changing of our neurons in our brain. And the other more recent thought is that maybe ketamine activates something called G proteins, which are messengers that go on and do more downstream things. So, while it's still somewhat largely unclear. The outcomes and the results have just been something else.
So ketamine became the first antidepressant recently, correct, to be approved by the FDA in a certain form. How unusual is that, and what's surrounding this nasal spray?
Yeah, so we've had antidepressants for a long time, starting with the MAOIs and then the tricyclic antidepressants. And sort of big breakthrough was in 1989 with Prozac, where these are now the SSRIs that work on the serotonin system and were much safer than previous medications. But for a long time, there were a lot of Me Too drugs, other drugs that did a lot of the same things. The approval of this new ketamine formulation, it's Esketamine actually, it's one of the constituents of ketamine, is a big change, right? So it is in fact a nasal spray that patients use in the office, they're monitored in the office, and again, the thought is that if we can deliver ketamine previously via IV, which is what we do right now, continue to do, and now the nasal spray, that patients can get much better, much faster. There were studies with ketamine that looked at patients who came to the emergency room and they got one dose of ketamine, and sometimes some of the results were that their suicidal ideation just went away. I've heard that there are studies for Esketamine, the nasal spray, that are as remarkable, but they want to build out the network of outpatient providers before they start offering it in the hospital.
What was so you started offering the nasal spray, which sounds like there were a lot of hoops you had to jump through, given it is very tightly controlled and regulated as it should be. What was that process like for you as a provider, and what does the FDA require for you to actually treat patients? Yeah,
so the FDA approved the medication. Spravato is the brand name, Esketamine the generic name. But they said, okay, we're going to approve this, but you have to put in place what's called a REMS, risk evaluation and mitigation strategy. There's a lot of steps you have to make sure that it's not getting abused or it's not being used inappropriately. So the first was I had to register and certify as a provider. The clinic has registered and certified as both providers and not really a pharmacy, but somewhere where we dispense the medication, so pharmacy-like. And then with that, there's continual paperwork. We have to enroll patients into the program, continually send them information on how the patients are doing, what kind of adverse events they're having, and there's just a lot of back and forth, but a lot of paperwork as well on how to really make sure we're using this appropriately.
And does insurance cover Spravato for patients?
So we are seeing insurance companies cover Spravato. Interestingly, we were getting decent reimbursements for patients for IV ketamine as well. But the idea and what I'm so excited about for the Spravato is that if we can get, one, people just know more about it because it's been in the news, but also if we can get insurance on board, we can really get treatment for patients who have sort of maxed out other options that just haven't worked for them.
Well, I'm glad to hear that some patients have gotten reimbursement for the IV, because I think traditionally just reimbursement for any sort of mental health care is really challenging to get. From insurance. Yeah,
it has been, right? And there have been parity laws for a long time, even before the Affordable Care Act and certainly with the Affordable Care Act, that mental health and physical health should be treated the same. Unfortunately, that hasn't always been the case in practice. So we're really pushing to say, no, these are medical services. Psychiatrists now bill using the same medical codes that all physicians use. And I think it's making sure to get reimbursements for patients so they can get services where they might not otherwise be able to do so.
Now you've mentioned IV form and nasal form. Can you just take us through how you treat a patient with ketamine? What does that process look like?
Sure. So if we're going to use ketamine, which is effectively a mixture of two isomers, one of which is Esketamine, that's in Spravato, we give it to them through an IV. So they come in, we have a discussion, I get to know them, do a consent, talking about all the risks and benefits and alternatives to this treatment. And then the process itself, we start the IV, perhaps give them some medications for nausea, because some patients get nauseated. Not everyone does, but everyone hates nausea.
Yeah.
So we give it to everybody. Then they get a slow drip of ketamine over about 40 minutes. And really it seems like first of all, IV seems really good because it's going directly into your bloodstream, so it can be active in your brain. And the other point is that the duration of treatment, the 40 minutes seems to be really good compared to just getting it all at once through like a one-time shot. In fact, for chronic pain infusions, which ketamine has been used for even longer, the infusions are a minimum of 4 hours long. So, for Spravato, the nasal spray, somewhat similar. They come in, I get to know them. We go through the consent, and really there's a pretty straightforward process on how to deliver the medication into the nose. It feels a little different than your regular nasal spray, right? This is a little bit of a click to the mechanism. But
and that's done in the office?
In the office, and that's part of the REMS, that it has to be done in the office. And then the patient is monitored for at least 2 hours afterwards. For the most part, it's pretty straightforward, very well tolerated. And the goal is to, with IV treatment, see results in about 2 weeks. With just the way the nasal treatments are set up, sometimes it takes a little longer, a month or so, but still much faster than waiting for maybe your oral antidepressants to work, if they have. Most people have exhausted most of those options before they come to us.
Yeah. And what's happening in the office while they're receiving the drug? Are they experiencing anything in their minds?
Yeah, ketamine's not a hallucinogen. It's a dissociative anesthetic. So while maybe some people will say, oh, I see things and I hear things, it's more that they're dissociated from the room. They might feel like they're out of their body or out of the room.
Someone described it as just a very, very lucid dream.
Huh.
So,
okay.
Yeah, feeling like you're not in the room, but you know what's going on. And she even said sort of like after you sort of come out of it, it's like a dream where if you don't write it down what happened or someone doesn't ask you, you kind of don't even remember. She doesn't remember what she experienced.
And they could sit up the whole time and talk. And, these are sub-anesthetic levels, so no one is under anesthesia. But we really encourage them to lie back, close their eyes, listen to some music, and just release the room, just to make sure it's a nice, positive experience. For a rare, small percentage of people, it can become scary because it just feels different than anything else from what patients have said to us. So that's why we just want to have like a nice, calm experience.
I spoke to another psychiatrist in the area, Jennifer Dorr, who does ketamine-assisted psychotherapy. And so she believes very strongly in the combination of, using the drug in conjunction with therapy is how you get really the full effects. What's your thinking on that in terms of needing to have some sort of additional, not just taking the drug in isolation?
I think ketamine-assisted psychotherapy can be helpful. What we try to do, basically, as we were just talking about, really try to limit the stimuli that someone has during. So we don't do the psychotherapy before. Patients who are sort of my own patients, not referred by other providers, I'll do therapy before with them, sometimes after, but try during the actual infusion to give them a very sort of calm, quiet environment. So I think it has a role. We've taken it a different direction where we want if I could figure out a way to get rid of the blood pressure cuff and still know their blood pressure, I would, because it seems to pull them back to the room. I want to allow them to just sort of float away from the room and limit the stimuli as much as possible.
What are the potential risks of ketamine, and how do you sort of go over that with your patients?
Yeah, so every medication has risks. Part of the consent process where we talk about the first time someone comes in, I go overboard and talk about all the risks. I really like to be transparent. The most common things that will happen are people's blood pressure will go up, their pulse will go up. You pretty much predict that. Some people get nauseated, right? Maybe they'll have blurry vision or slurred speech during the process, during the treatment. It goes away pretty quickly at the end. They could have those feelings of dissociation. And there's a really rare but serious side effect called laryngospasm. That's when your vocal cords close. It's rare even at anesthetic doses, but I really want to talk to everyone that, hey, this is an emergency if this happens. We have the equipment to take care of it, but you have to be aware that this is a risk.
Have you ever seen that happen?
I've never seen it happen. I've heard of it once. It was in an emergency room where they were using ketamine for anesthesia for a child to, I think, set a shoulder or something. And I don't know what the procedures were, but they accidentally had drawn up 10 times the anesthetic dose. Wow. And the child had a partial laryngospasm. So all they did was watch. and it resolved in time. So we're ready for that. I have all the equipment. I hope to never, ever have to open that kit, but it's there if we need it.
How do you see we talk a little bit about weighing the risks against the benefits of ketamine, especially given what the people who are arriving at this point of needing ketamine are dealing with in their daily lives, if they have major depression, if they're suicidal. How do you see that? So just the weighing of the risks and the unknowns about ketamine against the potential benefits.
Yeah, it's really crucial. So anything we do in medicine, we should really be cognizant of what are the risks, what are the benefits. If I'm going to get a CT scan, what are the risks of that? There's sort of radiation risk, but if I need to know if I have a bleed in my brain or not, I will accept that risk because I'm going to do something with that information. With the ketamine, as you said, people who are considering this is not, I got a bad grade on a test, I'm feeling down, I need some medicine. No, this is, I have clinical depression, major depressive disorder, and I have tried a lot of other options. The immediate risks we know, those mostly the ones we talked about. The long-term risks are largely unknown. So it's really weighing what are the known risks of the morbidity and mortality of depression and specifically suicide. Those risks are known versus the unknown risks of low-dose occasional ketamine infusion. For most people, I think the weight would be that the benefit of treating severe depression or suicidality outweighs an unknown risk. But I really try to be upfront about this, that we don't know. It's hard to know what the future will hold. Prozac's been out for 30 years. I know what those risks are. Ketamine, it's still too early to really know.
Because of the known versus unknown, is it more likely that psychiatrists at this point are trying to go through the whole range of Prozac and traditional, more longer established drugs before getting to ketamine? Is that kind of
I think so, and I think that's wise, right? Yeah. Now, do you have someone try 32 medications before you get there? I don't know about that, but certainly ketamine and esketamine are not first-line agents by any means. So trying other medications first, and oftentimes they work, right? For most people, they are helpful. And as well as psychotherapy and other treatments, behavioral activation, going out, doing things, being social, all of our traditional treatments, but then saying, is there something else that we need? And I think ketamine and esketamine provide another option, which we didn't have before. The options past medication and psychotherapy previously have really been TMS, transcranial magnetic stimulation, or ECT, electroconvulsive therapy.
Which more invasive.
They're more invasive. TMS is maybe not specifically invasive, but really sort of challenging to get. It's an everyday kind of thing for a month. Yeah.
They've studied that at Stanford.
Yeah, and ECT works great, but there's a very real risk of memory loss. Only the most serious cases would ever consider ECT in the past. We're actually seeing people come to ketamine before considering ECT sometimes. So I think that is the way you have to balance the risks and the benefits.
Yeah.
I'm curious where you see just with more clinics offering ketamine and the FDA approval, sort of where you see this all going in the next 5 to 10 years, and with sort of, I think, psychedelics in general becoming more talked about in mainstream as a treatment for mental health.
Yeah. I am cautious given my addiction work.
Yeah.
As I said, this is somewhat of a departure for me, but the results were so incredible, I said this can't be denied. What I am optimistic about is that we are now researching and developing new treatments that we didn't have before, right? Every few years, a new antidepressant would come along. It was a little different than the last, but largely basically the same. Now looking at, in this case, ketamine, esketamine, psychedelics like psilocybin, and pathogens like MDMA, ecstasy, I think as with everything, we really have to be cautious about what that means and be very thoughtful about bringing those things to market and to clinical care. But I am really optimistic that new treatments are coming and different treatments. Just how perhaps biologics have revolutionized the treatment of autoimmune disorders, or immunotherapy is radically changing cancer treatment. I think hopefully there are new treatments on the horizon for mental health as well.
It sounds like research into ketamine is progressing then.
It is.
And there'll need to be a lot more.
There will be, right? So this ongoing research, and it's interesting because probably because of the approval of Spravato, physicians are becoming more open to this as again, not first line, but more mainstream option. That this is not a fringe thing that mad scientists do in their garage. This is something that there is a growing body of evidence and literature to support, and seeing that maybe referring patients to this could be an option.
Were there any topics related to ketamine that we didn't touch upon that you wanted to mention here?
I think we hit a lot of the main points. Just remembering that certainly what we should never do is patients say, well, if ketamine is good, maybe I can just try to get it off the street or something. And because one, that's dangerous for a lot of reasons. Who knows what you're getting, but then sort of the abuse potential as well. Being very cautious that all these new treatments, if they are psychedelic based, don't turn into another sort of addiction epidemic in the future.
Yeah. Don't try this at home.
Don't try this at home, right? So the chances of that are probably lower than something like opioids, but again, being very thoughtful about where we're going in the future.
Okay. Rameen Ghorieshi, thank you for being here. Appreciate all of your insights.
My pleasure. Thank you.
That wraps up this edition of Behind the Headlines. If you think there are others who are interested in this topic, you can share this video or podcast by clicking the share link below or going to paloaltoonline.com/podcasts. Follow all the Palo Alto news on paloaltoonline.com, and we'll see you next week.